Good morning, everyone. I'll be speaking on diagnosis, prevention, and management of CKD in cirrhosis. Renal failure is a challenging complication of liver cirrhosis. There's high risk of death while awaiting liver transplant and reduced survival after liver transplant versus without renal failure. MELS score identifies patients with renal failure and increased allocation of liver transplant to such patients. We have detailed knowledge of AKI in cirrhosis. However, CKD in cirrhosis is relatively upcoming. Prevalence increased from 1% in 2005 to 46.8% in 2019. And the contributing factors are increasing in diabetes, hypertension, NAFLD, risk of de novo CKD amongst resolved AKI, and AKI to CKD continuum. Pathophysiology of renal failure, it is primarily related to disturbance in the circulatory function. Portal hypertension leads to activity and increased production of nitric oxide and endogenous cannabinoids, which leads to splanchnic arterial vasodilation, which leads to decreased systemic vascular resistance. In compensated cirrhosis, with portal hypertension, splanchnic arterial vasodilation, there is low effective arterial blood volume, which is compensated by increased cardiac output and increased plasma volume. So there is restoration of effective arterial blood volume. Whereas in cases of decompensated cirrhosis, there is markedly reduced effective arterial blood volume, increased cardiac output, and plasma is insufficient to normalize the effective arterial blood volume. So there is activation of sodium retaining and vasoconstrictor systems, which leads to sodium and water retention and ascites formation. There is further activation of vasoconstrictor systems and impairment in the cardiac output, which leads to renal failure. Pathophysiology of renal failure, bacterial translocation, production of pro-inflammatory cytokines, and nitric oxide in splanchnic circulation. GI bleeding, diarrhea, and diuretic use may increase hypovolemia and consequently renal failure. Renal failure commoner and more severe in patients with SBP. That's because there's increased levels of pro-inflammatory cytokines and long-lasting vasoactive substances. Other causes of renal failure includes use of NSAIDs, intrinsic renal diseases associated with cirrhosis, that is hepatitis B, hepatitis C, infection, alcoholic cirrhosis. Initial definition of CKD was serum creatinine of more than 1.5 milligram per deciliter, revised in 2011, where EGFR using MDRD equation, GFR of less than 60 ml per minute for more than 3 months. MDRD equation is not very accurate. We need to find better alternatives. But in spite of that, MDRD, and there is no requirement of evidence of proteinuria, hematuria, abnormal imaging, and pathology. Classification of CKD into structural and functional based on kidney injury. Functional CKD is usually reversible. Type 2 HRS is functional CKD, which is not reversible. There is persistent renal vasoconstriction and functional CKD, which progresses to structural changes. There were varied prevalence rates due to different parameters used for classification. One is study done by Dr. Rakhi ma'am. It was done at ILBS only on 818 cohorts of both hospitalized and outdoor cirrhosis patients, where MDRD6 was used and GFR of less than 60 was taken for more than 3 months and abnormal urine microscopy for more than 12 weeks. Incidence in this study of CKD was found to be 32.8%. Prevalence of CKD in cirrhosis, Rastogi et al. Prevalence of CKD, he showed that it increases with severity of CLD. Mahiwal et al. Reported prevalence of 32.8% patients with cirrhosis having CKD. Functional CKD is relatively uncommon and it accounts for 15.8% of renal impairments among cirrhotic patients. Determinants of increasing CKD prevalence, AKI to CKD continuum. AKI is an independent risk factor, adjusted hazard ratio of 8.8 for CKD. 25% patients develop CKD within 3 months with decompensated cirrhosis with AKI versus 1% without AKI. Odds of developing CKD are 31 with decompensated cirrhosis versus no decompensation. There is higher transition to CKD with increasing severity of acute kidney injury. Rakhi ma'am, Maiwal et al. All reported 32.8% patients having CKD, where 80% had one episode of AKI and 33% with AKI progressed to CKD. The determinants of increasing CKD, the mechanisms behind are poorly understood, but there is a possible role of maladaptive repair in the interstitial vascular and tubular structures of kidney, higher baseline creatinine levels, higher chances there are higher chances of developing AKI and lesser chance of resolution. And along with that, there is a contribution of diabetic and hypertensive nephropathy, which lowers the renal reserves. Increase in NAFLD. There is twofold increased risk of both incident and prevalent CKD amongst NAFLD patients. There is a role of pro-inflammatory state, insulin resistance, oxidative stress, and RAS. It is strongly associated with atherosclerosis, which augments the glomerulosclerosis. 20 to 25% of patients of liver transplant patients have severe CAD, and NAFLD also counts for increase in simultaneous liver kidney transplant. That was 8.2% in 2002 to 22% in 2011. This is basically the pathophysiology, where when there is cirrhosis along with portal hypertension, NAFLD with contribution from diabetes and hypertension along with atherosclerosis leads to structural CKD. And activated RAS, SNS, and AVP leads to renal constriction. That is leads to type 2 HRS, which further leads to structural CKD. Then sepsis, and that is the complications of cirrhosis, sepsis, GI bleeding, and medications leads to non-HRS AKI, which further leads to structural CKD. Then hepatitis B, hepatitis C, there is virus antigen immune complex glomerulopathy, which again leads to structural CKD. And in alcohol patients, there is increased IgA deposits. So because of that, IgA nephropathy, there is again it leads to structural CKD. What are the clinical implications of CKD in cirrhosis? Anorexia, anemia, ascites, bleeding tendency, and encephalopathy, they are both common to both CKD and cirrhosis. So decision for optimal treatment, it becomes difficult whether we need RRT. So this is how ascites develops: nephrogenic ascites, chronic fluid overload, hypoproteinemia, cardiomyopathy, all leads to formation of ascites, which are both common to CKD as well as cirrhosis. There is increased bleeding tendencies and thrombotic complications, refractory ascites in functional CKD. There is greater cardiovascular mortality, immunosuppression, increased immunosuppression, which leads to which predisposes the patient to infections, increased risk for HCC, which are seen in NAFLD, and increased RCC and transitional cell carcinoma, which are associated with CKD. Wong et al. Reported higher rates of superimposed AKI, 68% versus 21%, greater need for dialysis, 11% versus 2%, 30-day mortality was increased. There were higher rates of hospitalization, 70% versus 63%. Besigoda et al. Reported higher rates of AKI, 75% versus 45%, refractory ascites, 25%, bacterial infections, 58% versus 34%, increased liver transplant requirement, 25% versus 10%, and higher readmission rates at 3 months. That was 67% versus 37%. And it worsens the post-liver transplant survival mortality rate, 12% post-liver transplant with CKD versus 9% without that. Then evaluation of patients with cirrhosis and renal failure. renal function assessment, GFR of less than 60 ml per minute for 3 months. It's done routinely for patients with advanced cirrhosis, and it is especially important in patients with ascites, hyponatremia, bacterial infections, GI bleeding. Serum creatinine, it's the most widely accepted. GFR estimation with inulin and other iothalamate is a gold standard, but it's impractical. Cockcroft-Gault and MDRD equation, it overestimates GFR, but it is most widely used for GFR estimation, despite of the limitations. Creatinine clearance, it overestimates GFR, so it's not practical in the OPD settings. Creatinine-based GFR is most commonly used. It basically it overestimates GFR. Because of there is decreased conversion of creatinine to creatinine, there is increased tubular creatinine secretion, and there is underestimation of creatinine by increased bilirubin. It overestimates GFR by around 18 ml per minute. MDRD6 equation is recommended for use in cirrhosis despite of its limitations, where age, sex, serum creatinine, albumin, and BUN are used as variables. Then cystatin-based GFR, it's a better alternative than serum creatinine. It is produced by all nucleate cells, exclusively filtered by GFR. Hepatic function, sex, race, tubular secretion has no effect. It is affected by hypoalbuminemia, elevated CRP, and leukocytosis. It's yet not approved for routine use, but combining creatinine and cystatin in equation would be a better predictor. The biomarker damage, conventional biomarkers like albuminuria, it has a limited role due to hypoalbuminemia, increased capillary permeability, and it will not exclude parenchymal damage. Newer markers like NGAL, urinary neutrophil gelatinase associated lipocalin, interleukin 18, liver type fatty acid binding protein, kidney injury molecule 1. Newer markers, they are suggest damage started in AKI, role in CKD not very clear, and the cutoff values are not defined. UNGAL, it distinguishes functional and organic AKI. It increases in renal vasoconstriction, that is HRS and infections. So it loses its prognostic value and severity of CKD. Future markers, they are urinary microRNA, osteopontin, metalloproteinase 1 tissue inhibitor. Role of Doppler ultrasound. It is a simple non-invasive method to study intrarenal hemodynamics. It assesses renal vascular resistance as a vasoconstriction marker. Increase RI, that is renal resistive index, it detects early renal dysfunction. RI increases with severity of CKD from no ascites to ascites to development of HRS. It is correlated with renal structural changes, glomerulosclerosis, interstitial fibrosis, and arteriosclerosis. Differentiation of functional versus structural CKD. It has both therapeutic and prognostic implications. Structural CKD, it has an indolent course and a better survival rate. And features would be proteinuria of more than 500 milligram per day, hematuria of more than 50 per high power field, decreased cortical thickness, scarring, increased cortical echogenicity on ultrasound. Biopsy is a confirmatory, but it is challenging to do biopsy in cirrhosis patients. A summary of renal function assessment, evaluation of renal function. Serum creatinine should be measured daily in patients with acute impairment. Increases of 0.3 to 0.5 milligram per deciliter may indicate reduced reduction in GFR. Serum sodium and potassium should be monitored daily with acute renal failure and monthly or every other month in patients with CRF. Hyponatremia is common. Potassium sparing diuretics should be discontinued to prevent hyperkalemia. Electrolytes and protein should be measured preferably in 24-hour urine sample in all patients with renal failure. Significant proteinuria and urine sediment abnormalities usually indicates parenchymal renal disease. Renal ultrasounds rule out urinary tract obstruction, but ultrasound appearance of kidney is normal in most cases of cirrhosis with renal failure. So abnormal renal ultrasound, it indicates chronic parenchymal renal disease. A renal biopsy is helpful when a parenchymal disease is suspected because proteinuria or amendments, and it also decides in helpful in deciding the need for simultaneous kidney transplant in candidates for liver transplant. Liver biopsy is contraindicated if there are severe coagulation abnormalities, and there is little information on the use of transvenous biopsy. Evaluation of renal function, liver disease should be evaluated by means of standard LFTs and abdominal ultrasound. Liver biopsy should be performed if diagnosis is not clear. Upper GI endoscopy is helpful for detecting gastroesophageal varices. If large varices are present, prophylactic measures should be taken. That is beta blocker varicose ligation. Assessment of bacterial infection. Bacterial infection should be ruled out in all patients with acute renal failure or worsening of renal function. Leukocytosis may be absent owing to hypersplenism in patients with cirrhosis and infection. In patients with ascites, cell count and culture should be performed to rule out the infection of ascitic fluid. Blood and urine culture should be carried out even in the absence of obvious signs of infection, and chest radiography should be performed to rule out lung infection. Differential diagnosis of renal failure and cirrhosis. Hepatorenal syndrome, there is functional renal vasoconstriction, which leads to decreased GFR with minimal renal histologic changes. There are several diagnostic criteria. Then hepatorenal syndrome is diagnosed on the basis of serum creatinine concentration is more than 1.5, which is not reduced by administration of albumin, and after a minimum of 2 days of diuretics, along with absence of current or recent treatment with potentially nephrotoxic drugs, absence of shock, and absence of findings suggestive of parenchymal renal disease. Syndrome is classified into type 1 and type 2. Type 1 is where there is serum creatinine level rises to more than 2.5 milligram per deciliter in less than 2 weeks. And type 2 is characterized by a stable or less rapidly progressive course than in type 1. Type 1 is associated with severe multi-organ dysfunction of heart, liver, brain, systemic circulation, and adrenals. Type 2 is characterized by refractory ascites. Differentiating HRS with acute tubular necrosis is difficult. Urinary cast would be present in both. Renal tubular epithelials favors ATN, and fractional excretion of sodium of less than 1% favors HRS, and presence of hypovolumic or septic shock before renal failure is suggestive of ATN. Other causes of renal failure: hypovolemia-induced renal failure. Hypovolemia is generally due to hemorrhage or excessive fluid losses, either renal losses because of excessive diuretic therapy, or GI losses as a result of diarrhea from excessive lactulose administration or GI infections. Renal failure occurs soon after the onset of hypovolemia. Parenchymal disease, it should be suspected as a cause of renal failure if there is proteinuria more than 500 milligrams, hematuria of more than 50 RBCs, or both are present, and ideally it should be confirmed by renal biopsy if this procedure is not contraindicated. Then differential diagnosis between ATN and hepatocellular HRS remains a difficult issue. Presence of renal tubular epithelial cells, as we discussed, it favors ATN. Drug-induced renal failure, current or recent treatment with NSAIDs or aminoglycosides, it suggests could be because of drug-induced renal failure. Management of renal failure in cirrhosis, general measures, it is dictated by severity of renal failure. It requires ICU admission, monitor and treat for any GI bleeding. Third generation cephalosporins to be given for bacterial infections. Adrenal insufficiency is common. We give hydrocortisone for that. Avoid excessive IV fluid administration as it leads to increased hyponatremia and ascites due to overload. Potassium sparing diuretics are contraindicated, and treat ascites with large volume paracentesis along with IV albumin administration. Diuretics for functional CKD, they are not prescribed because it worsens the intravascular. For structural CKD, we give diuretics. For diuretics and correction of diuretic resistance, we give albumin in decreased albumin states and correction of metabolic acidosis. Tolvaptans, they are helpful, but there are reports of hepatocellular damage in patients of ADPKD. Management of HRS, we give vasoconstrictor drugs terlipressin, norepinephrine, and midodrine, albumin, and other therapies. Vasoconstrictors are basically, they have limited efficacy in type 2 HRS. Then we have discussed this. According to the cause, we treat it. Basically, if there is volume depletion, we have to, according to the cause, we have to treat that. Then transjugular intrahepatic portosystemic shunt, it decreases portal pressure, improves kidney function, and it relieves ascites. It is effective in refractory ascites and functional CKD. The resolution of ascites in 83% of the patients were seen, and there is potential survival benefit in HRS, long-term as well as short-term. Cell-free and concentrated ascites reinfusion therapy. Extracorporeal liver support, that is molecular adsorbent recirculating system. But here the absolute survival at day 7 was reported by Mitzner et al., whereas Relief trial and Prometheus failed to show any survival benefit. Then we have to treat according to the etiology of cirrhosis. HBV, we have to treat with entecavir. And for lamivudine resistance, we use tenofovir. HCV cirrhosis, we have to treat with sobusvir. We can give in mild renal impairment. And glycicaprovir with prebensavir are given for all genotypes. For NASH CKD, we have to use statins along with SGLT2 inhibitors. It has shown to decrease the progression as well as decrease the cardiovascular mortality. RRT, there is a risk of sudden hemodynamic instability in patients with cirrhosis with CKD on hemodialysis. There is a sharp change in osmolarity and in electrolyte increase is the risk of hepatic encephalopathy, platelet dysfunction, coagulopathy, and there's increased risk of bleeding complications. So PD is a better alternative in such patients, and it also allows the ascitic fluid drainage. Overall survival is 50% at 1 month and 20% at 6 months. There is a combined effect of liver and renal failure along with associated complications, as mortality is higher with type 1 HRS than in type 1. Vasoconstrictor therapy does not improve overall survival. However, positive response to therapy is associated with better survival. Increased post-LT mortality with any renal dysfunction and presence of CKD at the time of liver transplant, it increases the risk for post-liver transplant mortality. This was a study where the development of CKD after AKI in patients with cirrhosis is common, and it impairs the clinical outcomes. HRS prevention. HRS risk substantial with cirrhosis and SPP. It is reduced with IV albumin. There is a positive effect of albumin on circulatory and antioxidant function. Norfloxacin prevents bacterial translocation, suppresses pro-inflammatory cytokines, and improves the circulatory function. Renal failure and liver transplant. Effect of MEL scoring. Number of patients with renal failure undergoing liver transplant. So this was data which I had collected on patients, or I had taken CKD and CKD on AKI patients. The total 76 patients I had taken, where 28 had CKD and 45 had acute on CKD. Dialysis modality in 44%, in 60% SLED was being carried out, and in 25% we MSD was being given, and 3% we were giving PD, and CRRT was offered to 9 patients. Cause of CLD, it was in 47%. It was NASH. Ethanol was there in 27%, and outcome was 34% of the patients are on maintenance hemodialysis, and 24%, that is 34%, have expired. So my conclusion is renal dysfunction commonly occurs in cirrhosis. There should be a low threshold for diagnosing these reversible causes of renal dysfunction. Diagnosis with newer equations is mandated. Pharmacotherapy should be used as a bridge to liver transplant. Renal function improves after improvement of hepatic function following liver transplant, and specific criteria set for eligibility for SLKT should be followed. Thank you, sir.